My brother-in-law is actually demolishing his old house right now, and he had to pay like $10,000 for a company that they have a license, state license, to remove the asbestos, and it's a significant risk, health risk, especially in cities like San Francisco and New York. They still have a bunch of it, and even here in the if the constructions were done below, I don't know what the cutoff year is, like 1962 or 1950 something, you have to pay one of these professional companies to do it. But you can see like the pleural plaques, you can see like calcifications on the chest x-ray, and obviously the CT is more specific and more sensitive for those calcifications. So if you look at these are the typical plaques, see like thickening of the pleural. So asbestosis until proven otherwise. This is obviously, you can't miss this. That's all calcifications in the plaques. And pleural fibrosis is rare, fortunately it's rare. And you can see this idiopathically, but you can also see it in some medications like bromocriptine. You guys remember why we use bromocriptine? I'm sorry? No, bromocriptine is actually a medication that's been still used for those patients suffering from prolactinomas. Like it's a dopamine agonist. Benign. Okay, so benign asbestos pleural effusion. These patients present with, like, after 20 years of exposure, they can have like a pleural effusion. So pleural plaques, you think about asbestosis. If they give you mesothelioma, that's what you need to think about. And 20 to 40 years after the exposure is very sad. And basically, criteria for diagnosis, you have like all these radiographic abnormalities, and ultimately you need to biopsy these patients. Talc-related diseases. I remember I got questions about talcosis, and IV talc injection. These are patients that they're actually abusing heroin, and they have like granuloma. Have you ever seen a skin popper, by the way? Have you ever seen someone doing skin popping? You guys know what skin popping is? So when IV drug users run out of IV access, they start like injecting whatever, the drug of preference. It can be methamphetamines, or it can be just opiates. They do it in the skin. So those patients actually, they have like these horrible lesions. Like they have like this thickening of the skin. Like the other day I got a patient that she's a skin popper, and she went in with like a pretty deep wound. When I started exploring the wound, I took out like 12 maggots from that wound. It was like she was completely full, like a fly, like a horse fly, just went in and then just put eggs. So if you see a skin popper, you're never gonna forget that. It's pretty impressive. I mean, it's very It's very disfiguring. Like you can tell, like when you guys observe like a drug addict, like look at the skin. Like they always tell us like, oh, look at the veins. They don't have any veins, but don't look at the veins. Look at the skin, because the skin popping is increasingly popular. When
like
sub-Q, they're so desperate. They don't have any more access. They just inject it wherever they need to inject it. It's terrible. Yeah, you're gonna see that. I guarantee you're gonna see. I've seen many patients with skin pop, and those patients, they frequently get admitted with cellulitis, MRSA. You know, if you're doing hospital rounds, you're gonna see skin poppers for sure. Guarantee you're gonna see that. Okay. Berylliosis. This is like a more sophisticated jobs, but is probably equally as bad. These patients get like chronic disease, and they think about like sarcoidosis, but you need to basically do what they call a transformation test. You need pathology to be able to diagnose it. Just based on the radiographic appearance, you're not going to be able to come up. So pleural diseases, we have, so I have the Jones criteria here, I think. So thoracentesis, we do it for two reasons. We do it for therapeutic or for diagnostic. When you have a new onset pleural effusion, you have to tap it because you don't know what it is. So make sure you guys understand that there's a lot of tests that are very helpful guiding or like showing you high yield or low yield for infectious versus non-infectious versus transudative. We do LDH, total protein, glucose, the pH. Remember, in bacterial pneumonia or in a bacterial complicated effusion, we call it a complicated effusion either because it's loculated or because it's a parapneumonic effusion. And that's a clear-cut indication to stick a needle to remove it, because these patients are not going to get better unless we remove that pus. So usually the pH is very low in those parapneumonic effusions. You can also do a gram stain. You know, every time you do any fluid that you remove from the body, you do a cell count, you do a gram stain, and you do a culture. And you can do other things, including looking for mycobacterial TB, looking for cryptococcal, or there's a very common infection here in California that you guys need to be familiar. It's called valley fever. Have you guys heard about valley fever? Valley fever? You know why they call it the valley fever? Because actually it's pretty common in the San Joaquin Valley. There's a big prison there, and a lot of the inmates they get it because it's a fungus that is everywhere in the environment, and it's called, you guys know? Does it ring the bell? So,
can you give us the first letter?
So on your boards they have a fungal infection that is very common in the East Coast, blastomycosis, and there's another fungal infection that is very common in the West Coast. And this is the one we have. Okay, it's coccidioidomycosis. So cocci is also known as valley fever. It's pretty common here. In fact, if you guys end up practicing in Bakersfield or like towards, you know, in the desert, like Barstow, in many areas in Central California and the San Joaquin Valley, every time you have a patient with pneumonia, you treat with antibiotics and fluconazole, because the incidence of cryptococcal, cocci pneumonia is very high. So yeah, make sure that it's a fungal infection, it's not a bacterial infection. Okay, this is the Lice criteria. Sorry, I was saying the Jones criteria. So you basically you can tell very accurately if you have an exudate. If it's a transudate, you can get a hit or miss. But if it's an exudate, you can very confidently call it an exudate, because they have a lot of like high protein, high LDH. You know, you can pretty confidently say, you know what, this person has an exudate. And the next question that you need to ask as a clinician is, why does he have an exudate? The most common cause is an infection, parapneumonic effusion or TB or something else. But for the most part, like, the light criteria is very useful when you do a diagnostic thoracentesis. This you need to know for your boards, because they're gonna ask you, they're gonna show you a case with this. Okay, So you can also do cholesterol if you have a chylothorax, you know, like a rupture of one of the lymphatic vessels, but the macroscopic appearance of the chyle is very distinctive. You know, it's like milk. It looks like very milky. So, but you can actually look at the for bilirubins for those patients that are actually cirrhotic, like a cirrhotic effusion. You look for like if you see a lot of red blood cells, obviously you think about like a hemothorax, either from trauma, malignancy, or pulmonary embolism, or even an infection can cause a hemothorax. So cell count and differential, so you guys always do that in every body fluid sample that you send. So one thing you know is that if you have a lot of eosinophils, you think about, you know, there's something parasitic, or there is something allergic. Like there's some vasculitis, like I don't know if you heard about Church-Strauss disease. These patients can actually have like a lot of like peripheral eosinophilia. But you can also think about other things like malignancy, tuberculosis, parasites, like Church-Strauss, like I told you. If you have a lot of lymphocytes, you think about malignancy and TB, and maybe tuberculosis. Maybe sarcoidosis, or sometimes when the patients have like a status post CABG, they can develop like a form of pericarditis, and they can also develop like a pleuritis and an effusion. These patients, they usually have a lot of like lymphocytes. And if you see mesothelial cells, you think about TB effusions, or patients with AIDS can actually present with mesothelial cells in the effusion. Okay, so if the glucose is very low, you think about a parapneumonic effusion, malignant effusions, rheumatoid arthritis, or any of the rheumatologic diseases, and some sort of vasculitis like Church-Strauss or lupus. When you have a lot of, you measure the amylase, you think about pancreatitis. You can even send a lipase, but you think like this is probably like an effusion related to an inflammatory process. You know, when you have severe inflammation in the abdomen, the lung can actually produce an effusion. So for you to be able to accurately diagnose it, you just send a body fluid amylase. And if the amylase is pretty high, you got the diagnosis. It's pancreatitis related. So the pH, I told you guys that the lower the pH is more like it's not good. Most of the times when it's low, it's actually a very bad infection, or you can even have a malignant pleural effusion, or you can even get a urinothorax. I actually have one patient once that he had trauma, and he created a fistula, and he was actually urine was going all the way to his thoracic cavity. Yeah, he was involved in a severe motor vehicle accident. Okay, so, and lastly, these are more sophisticated tests that you can send. If you send ADA, is adenosine deaminase, I think is the name of ADA. You think about an empyema or rheumatoid arthritis. If you have a high interferon level, you think about TB. If you have high rheumatoid factor, you think about rheumatoid arthritis. A very high ANA level, you think about lupus. If you have a lot of triglycerides, you think about a chylothorax, because that's basically how the lipids get transported back. And if you have pus or a positive culture, you think about an empyema. These patients with empyema, they always need to have a therapeutic thoracentesis, or sometimes they need a decortication surgery. They just need to go in, and they need to, when it's like actually pretty large. But nowadays, like I was describing earlier, interventional radiologists are so good that they can put a pigtail drain anywhere, and you can get away without surgery. Back in the days, these thoracic diseases carried a lot of morbidity and mortality because the interventions were very invasive. You know, they do a thoracotomy for everything. Now they do like less invasive surgery, like VATS. Have you guys heard about VATS? Video assisted thoracic surgery is basically the gold standard for thoracic surgery these days, where is a minimal invasive form of like gaining access to the thoracic cavity. It's like a laparoscopic, but in the thorax. And back in my days, everything was thoracotomy, and that carries significant morbidity and mortality. Okay, so these are like the American like Chest Society recommendations for parapneumonic effusions. I don't think you need to know this. This is more like when you're doing your internal medicine residency. Okay, lastly, I think this is the last thing, and I'm sorry, this is a very dense topic. So sleeping disorders. So sleep apnea, I talked to you guys earlier, like last week. Sleep apnea is a serious disease. So you suspect it if you have an obese patient, but the take-home message is that sleep apnea can happen in anyone. And that you gather that information from a polysomnography or a sleep study. And it's very simple. If you have very little event, you don't have anything. If you have anywhere from 5 to 15, we call it mild sleep apnea. And anything greater than 30, we call it severe sleep apnea. When somebody has more than 30 events, it's very disabling because they're falling asleep everywhere. They can actually get into car accidents. These patients, you need to report them. If they have severe sleep apnea, you need to disclose it to the patient and say, like, I'm sorry, but I'm mandated to report you to the DMV because until you get your sleep apnea treated, you shouldn't be driving. And that has medical legal implications. So I always tell students, like, because you're afraid of upsetting a patient, or you don't want to destroy your relationship with a patient, you can lose your license. And this has happened many, many times. You have a patient with severe symptoms. Like the other day, a patient left me because he wanted me to sign a paper. He's a diabetic with peripheral diabetic retinopathy, uncontrolled diabetes, approaching dialysis, and he drives a semi-truck. And he wanted to renew his license, and he wanted me to sign those papers for him. I told him, like, I'm so sorry. I'm really, really sorry, but I don't think you're stable for operating that. He got very upset, but you know what? You guys, imagine how much money and effort you spent, like, to get here, like, because you don't want to upset a patient. And this is not about upsetting a patient, this is to do the right thing. And if the patient is going to get upset, it is what it is. You just need to tell them, you know what, you have severe sleep apnea, I'm going to have to report you. It's like if you have a patient with a seizure, you have to report that patient. If you don't report, if you don't send a report to the DMV, trust me, if something happens, that's going to be on you because you mandated that you report these patients. Okay, so if you don't treat it, you can have hypertension, pulmonary hypertension, heart attacks, a stroke, arrhythmias, decreased quality of life, decreased job performance, and all sorts of madness. And you need to advise the patients to lose weight, to stop having any opiates or any benzos or any sleeping medications that may be exacerbating the problem. And you need to refer them to get the non-invasive positive pressure ventilation, CPAP. And that's how we treat it. Patients hate it, but the way I sell it to my patients is that you have no energy, you're feeling terrible, you're gonna feel so much better. And once they get used to it, they're so grateful. They say, like, you know what, I didn't realize like that I was so tired for so long, and now that I'm treating my sleep apnea, all my stamina is coming back.
My mom has one.
She does?
And my grandmother, but they say the same thing. They said, oh, I thought I could never wear it.
Right. And now they feel so much better that they cannot live without it, and they travel with the equipment because they know that it's really making a difference for them. So yeah, so we have one of the medical students had a sleep apnea, and he doesn't want to get the sleep study. I told him, like, you need to get it, man. He's gone? What's his name?
Was it Jonathan?
Jonathan. He's gone?
Yeah.
He's done?
Yeah, they had their last day.
Yeah, funny guy. Yeah, sleep disorder. So, okay, and the surgery, there are different surgicals. Patients are gonna want to get away just with the oral appliances. I don't think these oral appliances work. There's all sorts of things. If you go online, they're gonna want to try to sell you anything. But I'm not a pulmonologist, so I know that you need the CPAP. If you have severe sleep apnea, there's no way around it. Surgery and sleep in the machine. Okay, this is the Pickwickian, the obesity hypoventilation syndrome. So these patients have like more than, like, they're obese. They have like chronic hypercapnic, like CO2 retention. They are usually seen with sleep apnea, core pulmonary, and they die if you don't diagnose them and treat them. So this is the classic pig weekend. Okay, I'm sorry.
No, thank you so
That was a lot
much.
of information.
That was really great.
Yeah, no, it's my pleasure.